This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced, evidence-based discussion. When medication is mentioned, we'll use the generic name, unless referring to medicine listed on the PBS, in which case we'll use the commercial name. Please note that availability can vary between Australia and Aotearoa, New Zealand.
Are you listening to this episode between patients? Or maybe you're driving to work, picking up the kids, or doing your grocery shopping. We know it can be tricky fitting everything into your week, so we appreciate you taking the time to tune in. Talking O&G is designed as a CPD opportunity that fits seamlessly into your routine. There are just a few simple steps to follow to turn listening into CPD. Complete the form linked in the show notes to log your listening hours. Additionally, you can also choose to complete reflective questions to claim OM or PR hours. It's all part of the same form. Follow the link in the show notes to claim your CPD.
Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest RANZCOG guidelines and RANZCOG research with in-depth conversations with leading experts in obstetrics and gynaecology. I'm Dr. Heather Waterfall. I'm a generalist obstetrician and gynaecologist based in South Australia, where I'm the chair of the RANZCOG South Australia Northern Territory Committee.
And I'm Dr. Nisha Khot. I'm an obstetrician based in Victoria. I lead the O&G department at Peninsula Health, and I'm also RANZCOG's president-elect. Together, we are hosts for this episode. Joining us today are two expert clinicians who contributed to the development of the RANZCOG clinical guideline on abortion care. Professor Kirsten Black is chair of RANZCOG's Sexual and Reproductive Health Committee and served as deputy chair of the Guideline Development Group. Welcome, Kirsten.
Thank you for having me.
And we're also joined by Dr. Catriona Melville, a specialist gynecologist and sexual and reproductive health subspecialist based in Queensland. Catriona also played a key role as a member of the Guideline Development Group responsible for RANZCOG's updated abortion care clinical guideline. Lovely to have you here, Catriona.
Thanks for having me.
Let's begin with the guideline itself. Kirsten, why was this the right time to develop a binational abortion care guideline? And what were some of the guiding principles that were behind its development?
Yeah, it was the right time because decriminalisation had occurred across all legislations in both Australia and Aotearoa, New Zealand, and we didn't have any guidelines in this area, and it was important because it's also coincided with the development of a specialist pathway in sexual and reproductive health. So for those who are not aware, we now have a training pathway in years 5 and 6 of the RANZCOG Fellowship, and that enables people to gain expert clinical experience in abortion, contraception and sexual health.
Fabulous. So let's talk about early medical abortion, especially via telehealth. It's now much more accessible to have telehealth. And what are the factors that are important to consider in telehealth abortion provision?
Well, telehealth has been a really useful addition to abortion provision, and it's just important to say that it doesn't completely replace traditional in-person models. What we found telehealth abortion particularly useful for are our regional, rural and remote populations who can't always access local care. And telehealth models of abortion care aren't new. They've been around for many, many years, but particularly during the COVID-19 pandemic, they really came to the fore. And because of that, there's some great evidence base that arose from the pandemic. And just to draw your attention to a couple of really good papers, in 2021, there was a British study published in BJOG, and that was from Aiken, Lohr and Lord. And they looked at almost 30,000 patients that underwent a telehealth hybrid early medical abortion model. In the same year, there was also a Scottish paper in the BMJ Sexual and Reproductive Health, and that was Sharon Cameron's team, Professor Sharon Cameron from Edinburgh. And basically both these papers concluded that providing early medical abortion by telehealth is very safe and effective, but it's also very acceptable to our patients. I think in terms of other considerations, it's really important to know that telehealth models aren't suitable for everyone. So we really need to individualise care. And if you think about particularly people that might have language barriers, they may prefer an in-person consultation with an interpreting service available. The other population would be, for example, some of our women who are subject to reproductive coercion or forced or family domestic violence. And often the telehealth models that does have safety issues for those kind of populations, so you might want to consider in-person care. And then I guess the final point is really for all, as with all medical abortion, it's important to have a follow-up plan for telehealth. And that doesn't need to be in person. There's some great advances in terms of using things like low-sensitivity urine pregnancy tests for follow-up. But it's important to also ensure that there are local pathways. In the case of the very small likelihood of complications, that the person can access local care, which obviously can't be delivered by telehealth.
That's really useful to know, Catriona, especially given Australia's geography, that telehealth can be used quite safely and successfully for abortion care. Kirsten, I'm going to ask you about some of the practical stuff that is in the guideline. Things like what do we do with blood group testing, RH testing? What do we do with anti-D?
Yeah, so this was a huge improvement, I guess, on previous guidance, that we recognised that there wasn't evidence to give anti-D really before 10 weeks gestation. So we've removed that requirement for medical and surgical abortion. So there's no need to test blood group before 10 weeks. And indeed, the National Blood Authority took up that recommendation as well. So that reduces the need for unnecessary tests for women presenting for abortion care, and I think it was a great step.
Absolutely. You know, that is such an important message to get through, that you don't need to test for blood group and you don't need to give anti-D if you're not 10 weeks or over.
Correct.
And what about ultrasound? Because that's another barrier to getting care.
That's right. So what we recommended after examining the evidence is that with ultrasound, as long as you can be quite certain of gestational age on history, potentially with or without clinical examination, it's okay to proceed with an abortion before 10 weeks. But if there's any doubt, if you're suspicious of ectopic pregnancy, or there are other clinical indications that the pregnancy may not be proceeding, healthily, or there are other signs or symptoms that suggest that the gestation may be different to the one estimated by the last menstrual period, then ultrasound is recommended. And it's recommended also for those over 14 weeks gestation, in order to determine, to confirm the size of the fetus, but also the location of the placenta, particularly for those who've had previous uterine surgery. It's important.
Catriona, can you tell us what's currently recommended in terms of STI screening prior to abortion?
Yes, absolutely, Nisha. So the RANZCOG Guideline does recommend that routine STI screening is offered to all women seeking both medical and surgical abortion. It is important, though, that doesn't delay their care. So it's completely acceptable to do the testing on the same day as initiating treatment. So you should keep on top of your local STI guidance, and the Australian and the New Zealand Aotearoa STI management guidelines have got a list of what's recommended for asymptomatic STI screening. So for that, you would do an HIV blood test and a syphilis blood test. Hepatitis B would be done if the person is known to be not vaccinated. And then you would do a chlamydia and gonorrhea test. And the test of choice for that is a self-taken vaginal swab rather than a first catch urine test. It's really mindful just to give syphilis an extra mention, because we have got congenital syphilis, very sadly, in Australia. And the rates are definitely increasing in New Zealand as well. So it is critical that we test for syphilis at every opportunity in our pregnant population and in other at-risk populations. The other thing is that many STIs are asymptomatic, so it's quite useful just to have opt-out or universal screening in your clinic rather than to use a risk-based approach, because often people won't have symptoms and they will then decline the test. So it is a good idea just to offer these basic tests to everybody seeking abortion care. And I guess my final point is just that we want to mention the tests we shouldn't be doing routinely. So some of these tests have crept into routine use, and the ones at the front of my mind are Mycoplasma genitalium testing and also testing for bacteriovaginosis. And neither of those infections should be tested for in women that don't have symptoms. So no is asymptomatic screening, please.
That's really good to know which tests not to do, just as important as the tests that we should be doing.
Kirsten, just to confirm, the PBS describes the authority listing for MS2-step or mifepristone and misoprostol to necessitate a pregnancy that is less than 63 days gestation with an intrauterine pregnancy. We're comfortable that this guideline suggests that an ultrasound isn't required for that authority for prescription.
That's right. If you can confirm on clinical grounds through last menstrual period in someone who doesn't have any other suspicious clinical symptoms that would make you think of ectopic pregnancy or another complication, then it's fine to prescribe MS2-step on those grounds.
Catriona, in terms of first trimester surgical abortion, what are the safest surgical techniques recommended in the guideline?
So in the guideline, we looked at both techniques of MVA, which is manual vacuum aspiration, and EVA, electric vacuum aspiration, and we compared them both in terms of safety and outcomes. And the bottom line is that both techniques are very safe and effective and acceptable, so either can be used for first trimester surgical abortion. One thing that is important to note is that sharp curettage of the uterus is not recommended to confirm emptying of the uterus. It's not required. We can just use the suction cannula, and it has been associated with an increased risk of Asherman's, so we prefer not to use that technique.
So does that include the routine blunt curettage at the end of the procedure as well?
Yeah, I wouldn't say that any curettage is required at the end of a surgical termination. We can just use the suction cannula, and there's signs that the uterus is empty, or things like some foamy appearance in the cannula, the gritty feeling, and the feeling of the uterus contracting around the tube. Some people do the technique under ultrasound guidance. That, of course, is not necessary for those first trimester gestations. But all those clinical means are perfect in checking that the uterus is empty, and you don't need to proceed to cure out the uterus in any way, shape or form.
That's good to know. Thank you. Following an abortion, contraception is an absolute key consideration. What guidance does the guideline offer around timing, method selection and access, particularly for our LARCs, our long-acting reversible contraceptions?
Yeah, so IUDs can be inserted at the same time as a surgical abortion, and an implant can be inserted on the day of the procedure as well, both for first trimester and second trimester abortion. With the implants, they can also be provided at the time of medical abortion. So in some ways it may be counterintuitive that you're giving an anti-progesterone and a progesterone, but certainly with implants it doesn't seem to impact on the efficacy of medical abortion. We know from evidence that providing long-acting reversible contraception at the time of abortion is going to reduce the chance of that woman returning for a repeat abortion. And if you don't provide it immediately, then it's just less likely that they'll come back to have that method provided. And we recommend, choice in contraception, but often we find women presenting for abortion have been using a user-dependent method of contraception. Around half maybe are using some form of contraception that they were unable to use for whatever reason consistently. So it's important to provide balanced consultation, but I think one of the most important issues is efficacy in terms of contraceptive.
So you said insert a IUD at the time of a surgical abortion, and if they choose to have a medical abortion, when can I get them back to get an IUD inserted?
Yeah, so as soon as you know that the abortion is complete, so the pregnancy has been expelled and you're reasonably certain that the cavity is empty, so generally within 5 to 7 days of the medical abortion, it's reasonable to consider inserting an IUD. And it's important because actually you can get pregnant very soon after an abortion, so definitely you don't need to wait till the next period to bring someone back. Really take the opportunity to provide very good counselling and service and contraceptive provision at the time, whenever possible.
take the opportunity while they're there.
Kirsten, you said that we could send an STI screen off and not need to wait for the results to be back, but we're also putting in LARCs immediately after a surgical abortion. What's the risk of, having an STI that is not known and then we put in a LARC and things get worse?
That's correct. I mean, it's fine to put in an IUD without knowing the result if clinically there's no signs of pelvic infection. And when the results come back, it's just very important that you have a recall mechanism so that the woman can be treated immediately and partner notification occur. So it's absolutely okay to do that. That's accepted guidance and accepted in many international guidance documents that it's fine to actually just test at the time and treat if it comes back as positive, but certainly proceed with the contraception provision.
Thanks very much, Kirsten. That's really useful information.
Catriona, we were talking earlier about the gestations that we should be prescribing our mifepristone misoprostol up to. Is there an ideal gestation? If a woman walks in the door at 4 weeks and 2 days and she's got a positive urine pregnancy test, or she's on the phone at 4 weeks and 2 days, can she take her mifepristone misoprostol straight away, or should she wait for longer?
That's a great question. So traditionally what we've waited for is a complete confirmation of an intrauterine pregnancy, so visualising either a yolk sac or a fetal pole or both. But more and more, the models of care have moved to something called very early medical abortion, which is where you can initiate a medical abortion before you see the yolk sac and fetal pole. So that could be as early as 5 weeks gestation, for example, sometimes earlier. Now, there was a very large international randomised controlled trial, the VIMA study, that's just been published in the New England Journal, I think the beginning of this year. It did show that doing a VIMA abortion is just as safe and doesn't have any worse outcomes than delaying abortion care till you see the intrauterine pregnancy. There's a slight caveat to that is there's just a very small question mark over people that are very, very early, so with a completely empty uterus. And they maybe seem to have a slightly higher rate of continuing pregnancy. And I'm talking about that person you mentioned at 4 weeks gestation. The study wasn't powered specifically to look at those people, but they did make a comment in the paper around that perhaps it would be better to slightly delay initiation of drugs in those women. So I would say really sort of the 5 to 6 week gestational period when there's maybe a sac but no pole, no yolk sac yet would be the preferential time to start that. Obviously, if we are doing things like the no-scan models of care that we've discussed earlier, you won't know exactly what you're seeing, but you could look at starting somebody maybe 5.5 weeks post-LMP.
Catriona, one of the key concerns clinicians have is related to retained products of conception. What are the risks of this occurring? Are they higher in one versus the other, medical versus surgical, and what should we do about it?
Yeah, it's a really interesting subject, and it often deters clinicians from recommending medical abortion, I feel, because they do think there's a very high risk of having retained products. The risk is actually quite low. It's less than 5%. Granted, it is higher than those women having surgical abortion where the risk is usually less than 2%. But as I've just said, you can have retained products with both methods, so it's important that women still have choice. In terms of looking at retained products conception, though, it's important that we recognise that not all retained products conception actually need treated. So we have to evaluate women clinically. And one thing that often causes a bit of concern with women and their clinicians is that we do ultrasounds far too early after medical abortion, or we do them routinely. And we shouldn't be using ultrasound as a routine method of follow-up after medical or surgical abortion. So what happens then is we find these clinically insignificant retained products, and it's quite normal to have debris in the uterus in the days or even weeks after a medical abortion. Usually these self-resolve, but then we over-investigate and therefore we're over-treating women. So ideally, don't do your follow-up by routine ultrasound. I would not recommend that. And then if women do have retained products and they're symptomatic and they're clinically significant, we can then look at what the methods are for managing these. So the guideline recommends that expectant management, medical management, or surgical evacuation can be used. Some of these would depend on the clinical situation, so clinical stability and how severe the symptoms are, and also patient choice and local service availability. In terms of looking at surgical management, we mentioned manual vacuum evacuation earlier, so MVA. That's a fantastic choice for removing retained products surgically, and it can be done as an outpatient with local anaesthetic. So it's just another technique that you can add to your repertoire if you're looking at setting up a service or just trying to improve access for your women locally.
Thanks, Catriona. I think there is a question of overdiagnosis, but also the causing anxiety for women who may be asymptomatic and have something that is really not clinically significant. So it's very important that we choose what we do very wisely. How about when abortion completely fails and there's an ongoing pregnancy? What do we do in that situation?
Yeah, so that situation is very uncommon because we know that medical abortion, the chance of having an ongoing pregnancy is less than 1%, more like 0.1%. But if that does occur, the choices are to offer a repeat medical abortion, depending on the gestation the woman is at, or a surgical abortion. There may be a small number of people that choose to continue with the pregnancy, and it is important in those circumstances that they are aware of the slight increase in fetal anomalies associated with the misoprostol use, because in fact mifepristone use has not been shown to have any increased risk in anomalies, whereas we know that, for example, the rare syndrome of Mobius, where there's some cranial nerve palsies, etc., that can be associated with misoprostol use. But overall, the increased incidence of anomalies is very low over the background rate. And also very few women do choose to continue the pregnancy anyway, because often the reasons that they wanted to terminate in the first place are still there. So yeah, I would be more than happy and comfortable, and it's supported in the guideline, to offer either repeat medical or a surgical abortion in that circumstance.
Thanks, Catriona. Kirsten, the guideline places a lot of emphasis on person-centered care and informed choice. What does that actually look like in a clinical setting? How can we make sure that the women we see feel supported, respected, and well-informed?
So it's really about treating individuals with respect, acknowledging their unique values, beliefs, and perspectives, and taking that into account when discussing their care and engaging them in the decision-making process. It's important and also taking into account cultural beliefs particularly, and making people feel safe in the environment, being non-judgmental, particularly in abortion care, because it's quite a stigmatised area of healthcare. Shared decision-making, respectful care, really the key, I think, to person-centred care.
And Kirsten, we haven't really spoken about how things might be a bit different in New Zealand. Do you have any information about that? Is similar abortion care available in New Zealand as well?
Yeah, so in New Zealand there is a organisation, Decide, which is run by the Ministry of Health, and that enables free access to medical abortion in Aotearoa, New Zealand, and that is available to New Zealand citizens. In terms of surgical abortion, there is also access to surgical abortion, and the choice, as in Australia, in terms of offering choice of method, really depends on availability of local practitioners and services. So ideally we would offer everyone the choice of medical or surgical abortion. In practice, in our setting and certain parts of New Zealand, that's not always available, the option of particularly of surgical abortion, and also depends on the skills of the local practitioners. So we'd like to, in terms of person-centred care, of course, we recognise that, both Indigenous populations of Australia and Aotearoa, New Zealand, have historically not had equality of access to sexual and reproductive health care. They've not potentially felt safe or had culturally appropriate information about contraception, about abortion. And so I think that's really important that we address those inequities in our service delivery and potentially, ideally provide services that are led by Indigenous healthcare providers.
Thanks very much, Kirsten and Catriona. That's been so useful. To wrap up, I'd like to hear some key takeaways from both of you. Something you'd want every RANZCOG member or trainee to remember when providing abortion care. Catriona?
Oh, there's so many, Nisha, but I'll pick my favourites. So The earlier in pregnancy an abortion occurs, we know the safer it is. So it's really important to consider removing any barriers we can to access. So if you want to adopt telehealth or hybrid models and reduce unnecessary investigations, then that will definitely increase access to abortion. And we need to remember that unsafe abortion is a significant cause of maternal morbidity and mortality in other countries, and that medical and surgical abortion are both very safe and effective. And I guess my final point would be, do not arrange routine ultrasound after medical abortion for follow-up. It just leads to unnecessary over-intervention and causes a lot of anxiety for our patients.
Kirsten?
I'd like everyone to remember that abortion is healthcare and that it should be incorporated into the practice of trainees and fellows, and take the opportunity to train in this area of medicine because it's a goal. Equitable access to sexual and reproductive health care is one of the Sustainable Development Goals, and our countries should be, meeting those targets. Hopefully encourage some of you to consider taking up the advanced training pathway in sexual and reproductive health.
Thanks very much for that. My key takeaway from our discussion today is that sharp curettage is a strict no-no. The guideline recommends that we don't do sharp curettage, and I want every member and trainee to remember that that is not necessary if you're performing surgical abortion. Heather, did you have some takeaway?
I think my takeaway was in regards to investigations that I don't need every patient who comes to my abortion clinic to have an ultrasound scan prior, and I don't need to visualise something that shows there's an intrauterine pregnancy before I can offer an abortion.
And you don't need to check their blood group.
No, and I don't need to check it either. And don't give anti-D either if they're less than 10 weeks. Thanks to our guests, Professor Kirsten Black and Dr. Catriona Melville, for their insights, and thanks to you, our listeners. You can read the full clinical guideline for abortion care on the RANZCOG website, and we've included the link in the show notes. If you've enjoyed today's episodes, please rate, review and subscribe, and while you're at it, why not share the podcast with a colleague? It's a simple way to help others find Talking O&G. And don't forget, log this episode for your CPD. We'll be back soon with more conversations on the issues of shaping obstetrics and gynecology across Australia and Aotearoa, New Zealand. Thanks everyone.